for the, excuse me?
It was recording in progress, auto beeper. You can start, sir.
Thank you so much, Dr. Nitin, for giving me a chance to present this assignment. And my sense of gratitude to all senior faculty members along with you. I'll be presenting on HIV immunology, clinical features, and diagnosis. As you all know, the incidence of HIV in children and AIDS have gone down to a considerable level from 2000 to 2015, mainly due to timely antiretroviral therapy in the mother and preventing vertical transmission in children. And 70% of adults and children who are affected are in sub-Saharan countries, African countries, as we know. And worldwide, around 3.2 million cases of AIDS in children is there, and out of them, 9% of all living with AIDS. In India, it has been estimated that about 3.5% of children out of total 2.4 million HIV positive people are there, and adult prevalence is 0.31%. And most HIV infections, as we know, are from perinatal transmission, and intensive treatment during pregnancy and the care during breastfeeding, moreover, delivery, etc., will prevent a lot of new cases. Now, HIV virus is a retroviral virus and of a lentivirus genus. And it is mainly a cytopathic virus affecting almost all animals with different diseases. The characteristic is it is a cylindrical center with lipid bilayer. Now, lipid bilayer has two major glycoproteins, GP120 and GP41. They are derived from glycoprotein 160. Both are highly immunogenic. And GP41 and GP120, they have heterogeneous characteristic, and therefore it is difficult to produce vaccine in HIV. They mainly mediate recognition of CD4 cells and chemokine receptor CCR5 and CXCR4, which enables attachment and invasion. Inner sphere has two single-strand RNA genome, and each encoding 9 genes flanked at each end by a long terminal repeat sequence. Along with it, it has P24, P17, reverse transcriptase, integrase, and protease enzyme, which you can see here. Now, the long terminal repeat sequence is essential for integration of viral DNA into the host chromosome and also provide binding sites for initiating replication. Out of 9 genes, 3 are principal genes, that is GAG, POL, and envelope are the principal genes. GAG gene encodes core proteins, POL gene encodes the enzymes, and envelope gene encodes glycoproteins. Rest 6 genes are important for viral replication and enhancing HIV infectivity. Now, there are 2 types of HIV species, HIV1 and HIV2, and the main difference between them is the accessory gene in HIV2. And that leads to low virulence and low infectivity of HIV2. HIV2 infection mother to child transmission, and at the same time in children is very low. The incidence is very low. Initially, it was prevalent in West Africa, but now it is found in European countries and Southern Asian countries also. The genetic heterogeneity in HIV-2 makes it difficult to diagnose through common laboratory tests, and generally HIV-1 and HIV-2 tests are done together and then inferred whether the HIV-2 is there or not. The various subtypes of HIV have been found in specific geographical areas, and a particular person can be infected with different subtypes at the same time. And in India, subtype B and subtype E are more common, and subtype C. There are 6 phases in HIV cycle: binding and entry, reverse transcription, integration, replication, budding, and maturation. These particular slides summarizes the total 6 phases of the cycle and the action of some of the antiretroviral agents. Now, dendritic cells are first affected and virus binds to disease sign surface molecule. It doesn't infect the dendritic cells, and from there it reaches lymphatic tissue. The envelope protein GP120 and GP41 bind to CD4 cell receptors and co-receptors on the outside of cells. CXCR4 and CCR5, they facilitate viral entry. The P24 protein is involved in virus uncoating. Only core of the virus enters the CD4 cells, and cell enzymes stimulate the release of viral RNA and viral enzymes. These are the cells which are susceptible to HIV infection. And most important is macrophage and monocytes, which keeps the virus dormant for a long time. And in central nervous system, microglia and oligodendrocytes, they are very important. Now, HIV RNA to DNA conversion is mediated by the HIV enzyme reverse transcriptase. And the single strand of this new DNA then undergo replication into double-stranded DNA. The viral enzyme integrates, then inserts the viral DNA into CD4 plus cells DNA, and this is referred to as provirus. The CD4 cell has now been changed into a factory to produce more HIV. The provirus can remain dormant for an extended period of time, making it extremely difficult to eradicate. The molecular mechanisms of this latency are complex. HIV-1 reverse transcriptase is an error-prone and lacks error-correcting mechanism. And thus, many mutations arise, creating a wide genetic variations in HIV isolates even within an individual patient. The new DNA causes the production of messenger DNA, initiating synthesis of HIV proteins. The HIV proteins and viral RNA gather at the CD4 cell membrane and push through the different parts of the cell wall by budding. The HIV protease enzyme cuts the long HIV protein of the virus into smaller functional units that then resemble to form a mature virus. The virus is now ready to infect other cells. Now, there are some peculiarities that HIV preferentially infects the very cells that respond to it. It accounts for the progressive loss of these cells and subsequent uncontrolled HIV replication. And continued destruction of CD4 cells in GI tract brings about destruction in gut lining and subsequent leakage of bacteria in the blood. This enhances the inflammatory response, causing further decline in CD4 cells. HIV rapidly responds to immune system pressure by developing genetically complex population, and that successfully evades it. This is also one factor which prevents successful vaccination program. Monocytes and macrophages resist the cytopathic effect of the virus when infected, and with their long lifespan, acts as a reservoir of HIV and as effectors of tissue damage in organs such as brain. Within 3 to 6 weeks from the time of infection, HIV replication reaches a threshold and burst of plasma viremia occurs. And this intense viremia causes acute HIV infection or acute retroviral syndrome. And the patient can present as a symptom similar to flu or mononucleosis like fever, rash, pharyngitis, lymphadenopathy, malaise, arthralgia, fatigue, and raised liver enzyme. Now, few points about perinatal transmission. Now, perinatal transmission can occur at three places. Either it is intrauterine, intrapartum, or postpartum through breastfeeding. The main risk factors are maternal viral load at delivery, the gestational age of the baby, and the CD4 count of the mother. Now, intrauterine transmission mainly occurs in late gestation because the vascular integrity of the placenta is weak and microtransfusion across the maternal fetal circulation occur. And 20 to 30% of infected newborns are infected in utero, showing positive viral culture or PCR within the first week of life. Viral detection soon after birth indicates more long-standing infection during gestation and rapid progression to AIDS. A higher percentage of HIV-infected children acquire the virus intrapartum. And mucosal exposure to infected blood, cervical vaginal secretions, and intrauterine contractions risking late microtransfusion. Breastfeeding is responsible for as much as 40% of perinatal infection in resource-limited countries. Both free and cell-associated viruses have been detected in breast milk from HIV-infected mothers. Transfusion of infected blood products is a rare possibility which accounts for only 3 to 6% of all pediatric cases. HIV can rarely be isolated from saliva and has not been implicated for transmission as a transmission vehicle. The risk for household HIV transmission is essentially non-existent, and sexual transmission in pediatric population has not been reported except in adolescent population. Now, for infants acquiring HIV before or around delivery, disease progression is rapid. And 15 to 25% may develop AIDS within the first few months of life. And if left untreated, they have a median survival time of 6 to 9 months. They are rapid progressors. And neurological complications and opportunistic infection is seen more commonly. Recurrent GI infection, oral thrush, lymphadenopathy, and splenohepatomegaly is often seen. Most of them showing positive HIV culture and detectable viral load in the blood in the first 48 hours of life. 5 to 15% of HIV infected do not experience clinical or immunological progression despite a long duration of infection in the absence of ART. They maintain good CD4 count and have a low viral load. They are non-progressors. In children, many of them have mild symptoms for many years, and they may present as growth failure, recurrent infection, fever, diarrhea, chronic perotitis, chronic otitis media, nail and fungal infection, molluscal contagiosum are common presentation. And hepatosplenomegaly and lymphadenopathy can be there. Older children have growth failure, delayed puberty, and subtle cognitive dysfunction. HIV cardiomyopathy and ITP are also seen frequently. In end-stage HIV disease, when immune system has been exhausted by HIV replication and CD4 count is very low, severe opportunistic infection, fever, wasting, chronic diarrhea, and bone marrow failure are the presenting symptoms. This is the graph which shows relationship between viral load and CD4 count in an average course of untreated HIV infection, and it is very evident that the viral load and CD4 counts are inversely related in the severity. Revised CDC clinical categories of HIV in children less than 13 years. The category N, it is a non-symptomatic, children who have no signs or symptoms considered to be the result of HIV infection or who have only one of the conditions listed in category A. Lymphadenopathy, less than 0.5 centimeter, either at one site or bilateral, hepatomegaly, splenomegaly, dermatitis, parotitis, and recurrent or persistent upper respiratory infection. Two or more of these conditions listed will fall in mildly symptomatic cases, and none of the conditions in B and C. In category B, which is known as moderately symptomatic children, they have anemia, meningitis or pneumonia, fungal infection, disseminated fungal infection or local fungal infection, cardiomyopathy, CMV infection, diarrhea, hepatitis, lower respiratory tract infection, HSV infection, herpes zoster, lymphoid interstitial pneumonitis, nephropathy, nocardiasis, persistent fever, toxoplasmosis, and varicella disseminated. In category C, almost same infections, but in a very severe and fulminant way we see. And WHO clinical staging is asymptomatic stage 1, mild symptom stage 2, advanced symptom stage 3, and severely symptomatic are stage 4. In clinical stage 1, like what we saw further in the previous slides, the clinical stage 1, it is asymptomatic or persistent generalized lymphadenopathy. In clinical stage 2, there is persistent hepatosplenomegaly, papular eruptions, fungal nail infection, angular cheilitis, lineal gingival erythema, extensive wart infection, extensive molluscum contagion, recurrent oral ulcerations, unexplained enlargement of the parotid gland, herpes zoster, and upper respiratory infection. And clinical stage 3, there is, along with the malnutrition and wasting, there is diarrhea, fever, candidiasis, gingivitis, tuberculosis, bacterial pneumonia, and anemia and thrombocytopenia, and lymphoid interstitial pneumonitis. Clinical stage 4 has almost all the symptoms, all the conditions, except they have chronic toxoplasmosis and disseminated tuberculosis, acquired HIV-associated rectal fistula, etc., and Hodgkin lymphoma. Infant less than 1 year of age have a higher incidence of developing stage 3 defining opportunistic infections and mortality rates compared with older children and adults, even at higher CD4 counts, reflecting that the CD4 count may overpredict the immune competence in young infants. Pneumocystic pneumonia, cerebral toxoplasmosis, and cryptosporidiosis are the protozoal infections which are commonly found as an opportunistic infections. In fungi, Candida albicans, oropharyngeal, esophageal, vulvovaginal, disseminated, Cryptococcus neoformans, meningitis, and pneumonia. In viruses, CMV virus is more common, presenting as retinitis, colitis, pneumonitis, hepatitis, pancreatitis, herpes simplex virus in extensive oral ulceration, measles, varicella zoster, RSV, adenovirus, all may cause severe disease. In TB and atypical TB, non-tuberculous mycobacteria with Mycobacterium avium intracellular complex and most common cause of disseminated disease. Appropriate therapy with antiretroviral agent may result in immune reconstitution inflammatory syndrome. And determining whether the symptoms represent iris, worsening of a current infection, a new opportunistic infection, or drug toxicity is often very difficult. These are the opportunistic infection which we normally see, and it related CD4 count. At any CD4 count, we can have risk of tuberculosis higher in HIV positive people, and this can occur at any CD4 count. Kaposi sarcoma can occur at any CD4 count, though the risk increases when the count drops below 350 to 500. Below 300 count, we have diarrhea from bacterial infections, microsporidia and cryptosporidia, and skin problems, candida, thrush, dry skin, etc. CD4 count below 200, we have fungal pneumonia and chest infection, PCP infection, toxoplasmosis, and parasitic infections that can cause brain lesions. CD4 count below 100 is a Mycobacterium avium complex infection similar to TB, Cryptococcus fungal infection that can cause meningitis in the brain, PCP-like symptoms in the lungs. And CD4 count below 50, there is cytomegalovirus infection along with all other and a viral infection that can cause permanent vision loss and blindness, and it also affect other organs. CD4 percentage is more reproducible than CD4 count per se. This slide says that below 1 year, below 1 to 5 years, and below 6 years, stage 1, 2, and 3 is better reproduced if we have CD4 percentage count. Now, infants with HIV must be diagnosed as rapidly as possible to ensure the early institution of therapy to limit HIV-related morbidity and to prevent opportunistic infection. All infants born to HIV-infected mother test antibody positive because of the passive transfer of maternal HIV antibody across the placenta. They remain detectable till 18 months of age. Serological diagnosis reliable only after 18 months. IgA and IgM and anti-HIV assays have been IgA and IgM anti-HIV assays have been both insensitive and non-specific and therefore not valuable in clinical use. HIV culture detection by PCR or HIV antigen can be done below 18 months of age. HIV culture done from peripheral blood mononuclear cells is difficult, time-consuming, expensive, and for research. Positive results available by 1 or 2 weeks, and negative results are not reported till there is no evidence of virus replication for 30 days. Sensitivity is 50% at birth and 90% by 3 months. Single test not conclusive and should be confirmed by a repeat test or PCR test. HIV PCR are 2 types. One is qualitative and another is quantitative. Sensitivity increases rapidly to 95% at 4 weeks and 99% at 6 months of age. Either the DNA or RNA PCR is considered acceptable for infant testing. Infant who test positive during the first days of life assumed to have been infected intrauterine. Infants who test negative during the first days of life but later are found to be positive are presumed to have been infected intrapartum or postpartum. Thus, in non-breastfed infants, HIV PCR can be done at 4 to 6 weeks after birth. Breastfed infants should have been tested 12 weeks following cessation of breastfeeding. Now, HIV DNA PCR is mainly preferred to diagnose HIV-1 subtype B infection in infants and children younger than 24 months of age. It is highly sensitive and specific by 2 weeks of age and available and performed on peripheral blood mononuclear cells. False negatives can theoretically occur in non-B subtype HIV-1 infection and has been preferred for testing in young infants. And HIV RNA PCR is preferred test to identify non-B subtype HIV-1 infection, similar sensitivity and specificity to HIV DNA PCR in infants and children younger than 24 months of age. Enzyme-linked immunoabsorbent assay, most reliable method for detection of anti-HIV antibodies in children above 18 months of age. sensitivity more than 99.5% and specificity is of 99%. Positive test should be confirmed with a Western blot test or a repeat HIV ELISA test a year with a different kit. Western blot test is considered positive if at least 2 out of 3 bands are positive. Thank you so much for patient hearing. Thank you.
Thank you, sir, for putting up stress upon the usual pathology and at the end keeping it simple at the clinical diagnosis. We will do this part 2 with medications in the next session. HIV diagnosis, clinical evaluation is being covered in this, and next session we will be covering it up with the treatment part and how to prevent it from the vertical transmission. Thank you, sir.
Thank you so much. And the frank confession is that I have never been involved in the management of HIV.
I know, sir.
And I have never seen a patient, a direct patient involved in the total treatment and course of. So in spite of, because of this handicap, I have not been so natural in the collection of the literature and presentation because I have no backup of experience in these cases. This is only theoretical, and for which the audience will forgive me, making it a textbook-like presentation with my all knowledge that what I am talking. So thank you so much for bearing with me. Thanks to all the senior faculty members and my colleagues.
Thank you, sir, for taking out time. Take care, sir.